she passed away after 12 hours from the surgery. So the summary of this case is very concise. Can cement kill you in the way that you see? So bone cement was introduced in the 70s by John Charnley mainly, and we all know it's a mix that you do between a monomer, a polymer, and a catalyst, and at the end you will have a paste that would be used as a bone filler to void filler between the prosthesis and the bone. Bone cement implantation syndrome was first reported after 10 years of introduction of bone cement. That's a very long time. It is underreported, and it's usually described with the hip arthroplasty, especially in a fractured neck of the femur. But it may occur in any stage of bone surgery, also in other surgeries than arthroplasty. In the hip and knee, it can occur or start to manifest during the femoral reaming, during the acetabular or femoral cement implantation and insertion of the prosthesis. The last two items are the mainstay of this complication. It can even occur during the joint reduction, and in the total knee, it can occur after deflation of the tourniquet. A lot of literature has appeared concerning the subject, and unfortunately, it is done by anesthetists, not by hip surgeons. This paper is by Donaldson. This is the Herald study that coined the name bone cement implantation syndrome in the year 2009. We move to the definition of the case. We don't have a definition really that is agreed upon for BCIS. It's a confluence of clinical features that include intraoperative, immediate postoperative, hypoxia, hypotension, cardiac arrhythmias, increased pulmonary vascular resistance, and cardiac arrest related to the use of acrylic cement. It has three clinical grades, as known by the anesthetist. The first one is a moderate degree, which shows hypoxia with oxygen tension less than 94, a hypotension around, in the systolic blood pressure, around 20%. The medium or the middle grade, grade 2, shows more severe hypoxia, where the oxygen tension goes down to 88%, and the systolic blood pressure falls more than 40%. There might be in grade 2 an unexpected loss of consciousness, as I have told you about our case. The third stage is the decimal, with complete cardiovascular collapse that requires CPR and requires intensive care unit. This one has a very high mortality rate. The incidence is somewhere around 0.1 to 0.2%. It's not too much. But most of the papers talking about the incidence does not point really to the importance of systolic blood pressure and the oxygen saturation. I have put in the top the paper of Lafont, which is one of the oldest papers. Perhaps this is the only one that joins or marries the incidence to the systolic blood pressure and oxygen desaturation. You might see as well in the bottom that there are some incidence studies showing you that the incidence of bone cement implantation syndrome, or BCIS, in uncemented total hip replacement is 0%. Of course, this is related to the absence of cement, but the condition itself might be seen also in cementless stems. So don't count on this 0% that you see now. There is a significant transient and sudden drop in the oxygen saturation, which will lead to increased pulmonary vascular resistance. Consequently, the blood pressure in the arterial pulmonary system will increase. That's pulmonary hypertension, that's to say, will reflect back on the right ventricle and also in the left ventricle, reducing the filling ability of the heart. This will lead to a reduction of the stroke volume, a reduction of the cardiac output, and a sudden drop of the mean arterial pressure. This phenomenon is transient, but it may come and go, recur, that's to say, for 48 hours after the operation. The profound cardiovascular change will lead to severe arrhythmias, shock, and ultimately cardiac arrest. What is the etiology of this condition? We don't really know the etiology for sure. Nobody knows any evidence-based etiology, but there are 4 suggested models. The monomer-mediated model, that's volatile liquid that you mix in the cement. This is rather toxic. There is an embolic model, which is probably the strongest model. There is a histamine release and the hypersensitivity model, but perhaps the truth comes with a multimodal model where 1 or 2 of the above joins together to cause the pathology. We'll continue with our interleukin lady. At the autopsy, there was a widespread pathology, really. Not very strange to see after what I will tell you that she died. The lungs showed bone marrow elements in the blood vessels composed of fat admixed with hematopoietic tissue. The fat also was observed in the pulmonary sinusoids, blocked by fat. The heart showed marrow elements adherent to the endocardium. Fat and marrow elements were seen also in the blood vessels of the liver and kidney, and the kidney showed acute tubular necrosis. She also had very severe pancreatitis, an image of pancreatitis with infiltrating areas of hemorrhages and necrosis. The cause of death, as given by the pathologist, is disseminated microembolization secondary to hybrid total hip arthroplasty. What are the risk factors that you would keep in mind when doing these operations? I have chosen this paper because it's concise and up to the point. Most of the studies are on patients with fractured neck of femur, as I told you. The 2 important risk factors are poor pre-injury ambulatory status. Patients who do not walk well or did not walk prior to the operation. Those with underlying heart disease, chronic heart disease, especially cardiac arrhythmias. And those in which you will use a shape-closed femoral stem design in the cemented stem of your prosthesis. We know that the shaped closed femoral stem design is associated with high pressure in the lower third in the area of the bone cement interface. It is not exclusive to arthroplasty, as we said. This is one of the pointers that we know now, that it is also associated with the use of bone cement in tumor surgery. So beware of bone cement implantation syndrome. It might be the end of your patient life, and it will be a shock to you after doing a successful operation. In a nutshell, identify the high-risk patients, namely elderly patients with pre-injury low mobility or no mobility, elderly patient with chronic heart disease, especially arrhythmias, and in those where you will use cemented shaped closed stem. Befriend your anesthetist, and at the specific moment you're going to apply the cement, tell him that I'm starting now. So he would avoid volatile drugs like nitrous oxide now, because we already have a volatile drug in the cement monomer. He will also make sure that the patient has a good blood volume with a good systolic blood pressure and a good partial oxygen pressure. Please follow the proper cementation techniques, especially in the stem area, in the femoral area, by removing the loose cancellous bone and marrow debris, by using a lavage, by using a brush. Don't leave loose cancellous bone, don't leave marrow elements in the femoral canal, don't leave blood clots. If you have a patient with previous bone cement implantation syndrome history, you know that this patient on the other hip had an episode and went to the intensive care but did not die. Don't do cemented hip. Think of cementless choice. I'm leaving you now with secondary readings. These are not the most recent papers, but they are actually the best papers talking about the subject. I hope that my talk has added something to your knowledge, and thank you very much.
Thank you so much, sir, for this excellent presentation. Dr. Taimur.
Aywa.
We have one question for you, sir, please.
Yes, yes.
From Dr. Ahmad Qasim, any difference between cement only and antibiotic cement in this issue?
No, the antibiotic does not share in this phenomenon. The share comes from the monomer and from the catalyst. So there might be a difference in different types of cement, but there is no paper telling us that this brand of cement is better than that concerning the BCIS. But definitely adding antibiotics or adding barium, because some cement will have a barium content and some will not. Barium and antibiotics does not contribute to the phenomenon.
Yes. Another question from me, sir. This phenomena, does it affected by the state of the cement when I apply it? I mean, I have to apply the cement in the dewy state. So if I apply it in a slightly liquid state, does it increase this phenomena, sir?
Yes, the problem comes actually from the traditional learning of using low viscosity cement in the femur. But nowadays, really, we don't use the low viscosity cement. We use a medium viscosity cement due to many causes. One of them is what you said. The more liquid is your cement, the more the phenomenon of BCIS. This is due to the presence of volatile monomers still in the volatile or liquid status.
Yes, sir. And the last question, sir, please.
Yes,
yes, please. Please, sir.
Yes,
please, Dr.
Can I present? Dr. Taimur, Professor Taimur, it's very nice talk, presentation. I think I have also discussed this.
Your presentation is the nearest to mine.
Yes. Yeah. So today, I'm asking you, from your experience, do you like to do cementless procedures in this old age of neck femur? Do you prefer something like that, or according to the condition of the bone, osteoporotic fracture bone, or something we can do cemented also? Because the cementless has also its complications like periprosthetic fractures and else.
Exactly, it's a balance in the heart of the surgeon. The best method to avoid bone cement implantation syndrome is not to put cement, which means that you use a cementless stem. The problem here, and this is my personal preference, yes. I do not use cemented hips for fractured neck of femur, except in door 3, where you have a very wide femoral canal, pipe-like, no anatomical shape. And in these patients who are also osteoporotic, you will need to do a lot of reaming. You will need to put a very big size of the stem. And as we all know, these two procedures on their own increase the possibility of having a periprosthetic fracture. Definitely, the effect of a periprosthetic fracture, whether on table or early post-operative, is not desired. In the patients who are in door classification type 1 or class 1 or class B, the cemented procedure, I think, is as safe as the cementless, provided that you take care of what we have said. Don't let the patient come into operation in hypoxia. This hurry that I will do the operation tomorrow, and the patient comes into the theater with a hemoglobin 8.5, and you cause a lot of bleeding during the surgery. So probably at the time of the implantation, his hemoglobin is 6 or 5. You see, these are invitations for the condition. So in door class 1 and door class 2, I think there's a good cemented technique with good avoidance of risk factors, the ones I just discussed. The one you have influence in is to clean the proximal femur very well and don't leave loose cancellous bone or loose debris of marrow elements or blood clots.
But door type C, always cemented.
Door type C, I go for cement.
Yes, I agree completely. Yes,
because you put a Corée stem of size 14 or 15 in a patient who is osteoporotic. This is dangerous.
Very dangerous. Yes. So I think not the age. Not the age at the
no,
the
not the age. The shape of the proximal femur.
I accept you. I agree completely.
The age might influence what I have said about the pre-injury walking status.
Yes,
the more elderly the patient, the less of a walker. The younger the patient, the better a walker.
The risk factor, activity, daily living. Yes.
Exactly.
Yes, exactly. So thank you, sir. Thank you, Dr. Shashat.
Thank you so much, sir. Thank you so much, Professor Taimur, for this very interesting talk about a very important syndrome. Thank you so much, sir. A very important topic. Thank you, sir.
I'm sorry. Remember, when I wrote to you, I had a mistake in the spelling. I wrote it in a different way. It's BCIS. Okay. So sorry for my mistake.
Thank you so much, sir. Thank you so much. Thank you. Have a nice time, sir. Thank you so much. Our next speaker will be Professor Mohammed Chalabi from Denmark. Professor Mohammed will speak about Danish scenario in treating hip arthritis. Thank you so much for being with us, Professor Chalabi.
Thank you. Thank you for invitation yes. Can you see my screen now?
Yes, full screen, sir, please.
Yeah, full screen. Yes.
Yes, sir.
My name is Mohammed Chalabi. I'm an arthroplastic surgeon, consultant in Denmark now for about 20 years. I'm originally from Egypt, Kaskeleni University. I'm doing both hips and knees, and mostly 2 revision knees, but I'm doing simple revision hips as well. Today I'm speaking about Danish scenario in treating hip arthroplasty. Yes, we are having about from 100,000 to 100,020 patients coming with osteoarthritis every year to our primary sector or our hospitals. And it's a big volume, and we are just operating 10% the top of the pyramid. The rest we are usually using conservative handling, education, teaching the patient to understand the symptoms and the condition he have. We are using painkillers. We are having a special program, training program. I will speak about it. It's called the GLAD training, and we are having as well weight loss, either with training or medically. We have here Ozempic and Wegovy. They are made in Denmark. Novo Nordisk. Unfortunately, I didn't invest in the company before. We are using local injection therapy. We will speak about it. And the end stage, of course, it's hip replacement. It's about as I said, it's about 10%. Next. Oops. Yes. In the treatment of hip osteoarthritis here in Denmark, we just prefer to use non-surgical treatment, of course, and we are having 6 stations for it. It's, as I told before, patient education. We are having, of course, specialists are doing it, but general practitioners are doing it as well to relieve us. We are informing the patient this is it's not a dangerous diagnosis and he can live with it. He has no restriction in his everyday activity, but he can modify it to live with it. Teaching him about the symptoms and the fluctuation of severity of becoming very severe to becoming more mild, to differentiate between where the pain is coming from. It's coming from the back, from the hip, from the tendinitis, and it's a different treatment. We are using as well painkillers. Paracetamol, it's a standard here. We are sometimes using a non-steroidal anti-inflammatory if the patient can tolerate it. In severe cases, we are using opioids as well, especially the patient who can't sleep at night. Exercise, of course, we are having different modalities, including functional and neuromuscular training. And we are having our special program, GLAD. As I told before, it's about 13 years old, the program, started in Denmark, and I will speak in detail about it. Weight loss, it's not just for treating the pain, but it's to give the patient general condition much better to be operated and can train after operation, but as well, it will help the surgeon to have more easier operation, especially with patients with BMI over 45. Unfortunately, here in Denmark, we aren't like our neighbors in Sweden or no, where they have BMI limit. The patient must be under 40. We don't have it. We operate up till 50. But it's a very good idea to speak with a patient about it. And now we are having medicine like Ozempic or Wegovy beside treatment. Local injection therapy, we don't use it here in Denmark, and it's not recommended as treatment, but we are using it sometimes in diagnosis, especially gray zone patient where I'm not sure of osteoarthritis, giving the pain or other causes, but we are using it as a therapeutic, of course, with hip trochanter bursitis or tendinitis around the hip. We spoke about GLAD. GLAD in Danish, it's abbreviation for Good Liv med artrose i Denmark, or what means good life with osteoarthritis in Denmark. It's a treatment program began in 2013 at University of Southern Denmark for patients with osteoarthritis in knee or hip or long-term low back problems. And it's based with the latest scientific evidence and information taken as well from researchers and clinical experts and feedback as well from the patients who treated with treatment. GLAD are transforming this recommendation from the national and international guidelines to a structured program treatment. It consists with patient education and exercise as well data registration of the course of National GLAD Register. We are glad for registers here in Denmark, and I'll speak about HIP register as well we are having here. Clinician, and physiotherapists are entering data in the beginning and at the end of the intervention or the program, and the patient are filling 3 questionnaires in the beginning and 3 months after and 12 months after. The basic principle and idea of GLAD is we are helping you to help yourself, because it's very demanding and cost demanding, especially here in Denmark. Everything is expensive, so we want the patient to participate in it. He is our partner in it. The aim is to give the patient less pain, better functioning after GLAD, and better understanding of the nature of pain and what the patient can do themselves to improve the life. And it's very important here, because in Denmark here, our pension age are increasing. Our pension, it's not like I'm coming from Egypt, it's 60 years. Our pension here for most of jobs, it's 68, and it's now increasing to 72 to people who are born after 1975. I'm one of them. So that's why we want them to participate in the normal life. Referral, it's self-referral. The patient doesn't need any doctor. He can go to a physiotherapist and have it, or through general practitioner or specialist in the hospital. There is mandatory elements of GLAD, education of physical therapist. To have this patient education, we are training them. The patient must attend 1.5 hour sessions 2 times of education and explaining the program and the condition for him. And he must have minimum from 6 to 8 weeks training, and it's twice weekly, and it must be in GLAD units. As I told before, every information go to our registrations of patient data in National GLAD Registry. The GLAD patient objective, increasing the physical function for them, reducing pain, reducing the intake of painkillers, which cost as well, improving the quality of life, and of course, it's lower cost for our healthcare system. Now it's, as I told, it's 12 years now. GLAD, about 90,000 persons are included for the knee and hip osteoarthritis and followed the program. We are having now 350 units or clinics which are offering this GLAD. We are having about 10,000 patients. We had a drop, if you can see from this diagram, from 20 to 22 in this Corona time, but after that it's becoming 10,000 again. Physiotherapists and clinicians are trained to deliver this GLAD program, and they are having 2-day course in South Denmark University, and he must have certificate and license to do it. And that will give us a standard program for the patients, and we are having a standard training for them. Between this, from 2013 to 2022, South Denmark University have 25 training GLAD courses, and now we are having about 1,500 clinicians and physiotherapists are offering this GLAD training. Results, mostly, the most of result we can see it after 3 months, but after 1 year, pain are reduced in hips about 21%. It's more effective in knees. Reduced intake of painkillers with 22%. Higher quality of life, we measure it with walking speed, are increasing about 7% in hip osteoarthritis patients. The patient are having fewer sick leave, and it's very important for the economy here. It's about 12%. And compliance for GLAD about every 10 patients, 8 of them are finishing the program after 1 year. It's about 80%. It's very nice compliance, and it shows, it gives effect for the patient. Now GLAD training, it's not just Danish, it's becoming international, and they are having in GLAD international network in about 12 other countries where we are sharing information with them. They are having about 100,000 patients in knee. They are having 7,500 physiotherapists who have this license from GLAD certificate to give this training. There is more than 1,250 clinics are giving this GLAD training. And of course, if this training, it doesn't give effect and conservative treatment, we come to end stage for surgery. And we have a demand, it must be mandatory, must be 6 months treatment and other conservative treatment for them before surgery. And surgery, we are having here monitor with the Danish hip arthroplasty register, which was established in 1995. It's one of the first. The first one, of course, it's the Swedish knee register. It was in 1975. And it's a committee. We are having a chairman for it, and we are having a representative for private hospitals, one representative from Ministry of Health. We are having one representative for Danish Patient Association. The patient must be a part of it. As I'm saying, patients are partner in treatment here. We are having one representative from Danish Nursing Society. So we are having one nurse as well. We are having a representative for each Danish region. We are having 5, so we are having 5 representatives from Danish Society for Physiotherapy. We are having 1, and Arthritis Patient Association, we are having 1 as well representative, and of course, at last, 1 representative for Danish Society for Hip and Knee Replacement. We are having, of course, administration for this committee. We are having about this year 5 PhD students who are using the enormous data we are having from it. And it's a monitor system. It's like this novel 1984. We are a big brother watching you. They are watching. And we have, it's mandatory for us to report our operations and answer all these questions about the operation and the details of operation in this register. Reported operations in 2023, it's 14,350. Primary operation from the beginning, it's about 240,000 patients. Revision in 2023, it's 1,400 operations. We don't have 24 now. It comes 1 year after, because there is process for statistic and publications for the result. The coverage rate of reporting, it's very high for primary. It's about 97.7%. It's very nice. For revision, of course, for elderly, more old consultant doing revision, it's not active like this. It's about 93%. And we are having all the data about every hospital and about every surgeon in Denmark. We can see his result. Denmark, we are 6 million, and about 8% of those over 60 are having osteoarthritis. It's a big problem for us. It's a country for old men, as we are saying. People are getting more old. We are having a very effective health care system, and it's for free. And that longevity are becoming more and more. Indication for total hip arthroplasty, mostly as other countries as well, it's 83% osteoarthritis. We are having 9% for hip fractures, acute, of course, and acetabular dysplasia and burst, it's about 4%. We don't see rheumatoid arthritis as an indication in the last decades because there is efficiency and good chemical and biological treatment for it. Hip replacement therapy here in Denmark, we are using mostly spinal anesthesia and some general anesthesia. It's mandatory here to do electronic templating. It's not a choice. No, it's mandatory. We must do it. Robotic assisted surgery, yes, it's coming here. We are having 2 centers have it. We are having 3 different systems. Puri for Smith & Nephew, Mako for Stryker, and we are having Rosa as well. We are giving antibiotics, 1 doses, and we have international study and the national study for all hospitals in Denmark to compare between 1 dose to 3 doses. 2 years we finish it, and we are waiting for the results. We are using here posterior approach mostly. It's about 90% of surgeons here are using it. And incidence for surgery, it's about 240 per 100,000. It's very high and it's coming higher. In 2008, it was just 160 per 100,000 inhabitants. After the surgery, the patient are mobilized in the same day, and we are discharging about 45% of the patient in the same day walking, or the next day mostly. We are having a good pain management to have this treatment, and we are having a training after operation. We are having enormous data. It's about every prothesis we are using as well. We are having, and that's why as well, we are having a very cheap arthroplasty elements. It's the only thing in Denmark cheaper than other countries. It's because companies want to participate in this data and compare with other, like cementless acetabular components. We are seeing how much we will doing and how survival in 5 years, 10 years, and 15 years. It's the same for cemented femoral components like Exta and Corel and other, and it's the same survival, how much of it, cementless femoral component as well. We are comparing it. We are having data as well. As I'm telling, it's national, but we are having as well for every hospital, every department, and for every surgeon. We are having data and statistic for him. About 6.7% of primary hips were admitted for one reason or another 30 days after in 2023. 5% of osteoarthritis patients who undergo reoperation within 2 years after primary TOA, it's 5%. It's higher with patients with femur fractures. It's the same for luxation. In osteoarthritis patients who having TOA are more or less it's 2.7. In fracture patients, it's 6.5. Survival rate of osteoarthritis patient after primary with 5 years, it's about 96%, and it's been calculated for every hospital as well, so we can see it. Prosthetic infection is found in osteoarthritis patient during pre-operation 1 year after. It's about 1.2%. We are using a dual mobility lately, but for certain patients who are having risk for dislocation. Here we are using TOA, hip replacement for osteoarthritis patient. We are using mostly uncemented. It's about 70% the frequency of hybrid. We are having hybrid cemented stem femur and non-cemented acetabulum, it's becoming about 25%, and the cemented, it's decreasing for osteoarthritis, and it's depending in the age here. The more patient over 70, we are more to hybrid, cemented. Hip replacement for fracture patients, it's another picture, about 25% of them non-cemented, because we are looking as well for bone quality. Most frequently, it's about half of them are having this hybrid, cemented stem and non-cemented acetabulum. We are using still cemented total hip, but it's fallen a little bit. We are using mostly, it's about 90%. We are using metal head and polyethylene, because polyethylene now is very, very effective. It's not like before. Head sizes, most of the patients, 60%, we are using 36 millimeter. It's because the size of the patients, but it gives more stability as well. We are using to lesser extent 32 in 35%. And as I'm saying, we are having a lot of data to give us better choice for operations. And take-home message, good surgeons know how to operate, as we all know. Better ones know when to operate, and the best one when not to operate. But I'm adding, but the widest surgeons of all learns from others' faults and successes. And that's what we got from this hip register that we are having. And I know that Professor Mohammed Al-Ashhab was speaking about in Egypt. They are trying to have it, and it's a dream. And thank you. And this is my reference.
Thank you so much, my dear friend, Professor Mohammed Chalabi, for sharing your experience in a very important part of the world, the Scandinavian countries, especially Denmark and Sweden. I know that you are very interested in data collection and registration, and the Swedish registry is one of the biggest registry all over the world. I hope sometimes we can have the Egyptian registry, which has dream for all hip surgeons. Thank you so much for
sharing. Having open you.
Yes, sir. Yes.
Good luck.
Professor Chalabi, I saw your pictures in Hamlet Castle on the borders between Denmark and Sweden. It deserves to visit. I visited 10 years ago, and it's a very nice part of Denmark.
You are welcome at any time.
Thank you so much, sir. We have a question for you, sir, from one of our dear attendees. Any rules of preoperative injections with respect to pain and function improvement?
As I'm telling you, we aren't using it as a treatment for hip osteoarthritis, local injection. It's not recommended here. We are doing it because we are having another causes, trochanter bursitis, psoas tendinitis. So you must address your problem before you are speaking about the injection. But injections in treating osteoarthritis is not recommended here in Denmark. We are using it as a diagnosis. When you are having a gray zone, he has osteoarthritis, but not that much. So we make sure the pain are coming from the hip.
Yes, sir. Thank you so much, sir. And thank you so much for being with us. Our next speaker will be my dear friend, Professor Amr Hussain from UK. Dr. Amr Hussain will speak about primary hip replacement. Professor Hussain, thank you so much for joining us tonight.
No, first, salamu alaikum and good evening, everyone. And thanks, Prof. Ashhab, for the kind invitation and for having me today with you.
Dr. Chalabi, would you please stop sharing your screen, please, sir? Professor Chalabi? Would you please stop sharing your screen, sir?